Okie doke. So hope everybody's doing well. Today's topic is going to be on medications in pregnancy, specifically around tyranogenic medications. So this is a pretty broad subject. So in this presentation, I'll just be focusing on things that we as clinicians and providers should be considering when we're looking into starting or stopping a medication for pregnant patients. So we're all familiar with the pregnancy category system. This has been around since 1979 and has helped guided us in determining whether a medication is safe for our pregnant patients or not. Each medication is labeled category A, B, C, D, or X. A being this is a medication that has been studied very well in our pregnant patient and is considered safe. And X being that the medication should be avoided at all costs in our pregnant patients. So, however, since 2015, the FDA has been slowly phasing out the system. The reason is because often this system oversimplifies the risks versus benefits of each individual medication in pregnancy. A lot of times, patients and providers are looking at a medication, they see that it's pregnancy category C or D, and they'll totally dismiss it, even though the benefits of medication might outweigh the risks to the pregnant mother. So in 2015, the FDA implemented the Pregnancy and Lactation Labeling Rule. This rule aims to provide patients and healthcare providers with relevant information that allows for informed clinical interpretation and medical management. In addition, the rule seeks to avoid misinformation by mandating that prescription drug labels be updated as information regarding medications become outdated. So instead of giving each medication a pregnancy category, they summarized all the effects that the medication may have on the mother and baby. And also they give clinical considerations at the very end so that we as clinicians can evaluate the medication better and make a better informed decision on the medication in our populations. So let's take a look at an example. This comes from the package insert of everybody's new favorite medication, Ozempic. So you can see the pregnancy category is nowhere to be found. Instead, it has the risk summary. And the risk summary states that there are limited data with Ozempic in use in pregnant women to inform a drug-associated risk for adverse developmental outcomes. Based on animal reproduction studies, there may be potential risks to the fetus from exposure to Ozempic during pregnancy. Ozempic should be used during pregnancy only if the potential benefit justifies the potential risk to the fetus. At the bottom of the page, under clinical considerations, it states that hypoglycemia and hyperglycemia occurs more frequently during pregnancy in patients with pre-gestational diabetes. Poorly controlled diabetes during pregnancy increases the maternal risk for diabetic ketoacidosis, preeclampsia, spontaneous abortions, preterm delivery, and delivery complications. Poorly controlled diabetes increases the fetal risk for major birth defects, stillbirth, and macrosomia-related morbidity. So, as you see, this is a more complete summary, and it allows us to make better decisions when it comes to choosing to start or stop a medication. It also includes the section of that summarizes the data that they have. For Ozempic was not studied in pregnant humans. It was only studied in pregnant rats, rabbits, and monkeys. And now they also have a section on lactation and female and males of reproductive potential. Interestingly enough, I didn't know this, but they recommend discontinuing Ozempic in women at least 2 months before planned pregnancy due to the long washout period of Ozempic. So I guess it's something to consider in our patients who are trying to conceive. So when we're looking at medications that we want to start or stop, these are the 4 strategies that I suggest that we use. First is we want to consider the stage of the pregnancy. Second, consider the risks versus benefits of the medication. Third, be familiar with medications to be alert for. And fourth, knowing what resources we have available to us. So for the first strategy, considering the stage of pregnancy, we want to do this because different medications affect the mother and child at different trimesters. The most critical stage for fetal development occurs during the first trimester.
How are you?
Exposure to medications prior to 2
Lovely
weeks
day.
post-conception
Adam, can you please mute yourself?
usually has an all or nothing impact. Either nothing happens or there's a loss in pregnancy. 2 to 8 weeks post-conception is the highest risk for cleft lip and cardiac or neural tube defects. Some medications used later in pregnancies can impact neurologic development, organ growth, and lead to preterm labor. Certain medications may be safer to use in specific trimesters, for example, nitrofurantoin and Bactrim, which I'll discuss more in a little bit. The second strategy is to consider the risks versus benefits of the medication. And this is, when we do this by looking at the information on the package insert, the risk summary, and the clinical considerations. I wanted to share this example considering risk versus benefits. So for statins, as long as I remember, statins have always been a complete no-no in pregnancy. If you had a pregnant patient, we should avoid statins at all costs. However, with more recent data, the FDA is requesting all statin manufacturers to remove the contraindication in prescribing information against using statins in pregnant patients. Although statin therapy should be discontinued in most patients, healthcare providers should consider the ongoing therapeutic need of individual patients, especially patients with very high risk of cardiovascular events during pregnancy, such as patients with homozygous familial hypercholesterolemia or those with established CVD disease. So I wanted to bring up this example to illustrate the fact that when we're looking at these medications, it's not always black and white. And it's up to us to be diligent about, the changes in the information and knowing what medications are best for our patients. The second strategy is to be familiar with the medications that we commonly use that may be harmful to pregnant mothers. For example, in my hypertension clinic, I commonly use ACEs, ARBs, thiazides, and calcium channel blockers. For pregnant mothers and females of childbearing age, I generally avoid ACEs and ARBs because ACEs and ARBs can cause death to the fetus in pregnancy. In fact, I can't really think of a situation where the benefits of using ACE or ARB will outweigh the risks, especially when there's good alternatives like hydralazine, nifedipine, or labetalol. Sorry, was there a question out there?
I do have a question. No. Sam, you're unmuted.
Okay, got it.
But that's not my question. My question is, you do your hypertension clinic by protocol. Do your protocol, I've never seen you take one of my patients who has hypertension of reproductive age and not put them on an ACE or an ARB. So I would really like to know, is this new? Do you have a protocol? Like, what are you doing? Because I'm not seeing that.
So I usually, the ones that I do put on ACE and ARB, I ask them first, hey, are you planning on having a child in the next couple of years? And then if they're not, then I talk to them, I discuss it with them and let them know, hey, this medication, is teratogenic, and if you find out you're pregnant, you should let us know right away. So I inform them very well, but for
Perfect. So you're counseling
patients,
them.
Yeah, I'm
It's
counseling.
not like a flat no, it's a counsel. Perfect. That makes more sense. Okay.
Yeah. So yeah, but most patients of childbearing age, I just stick with calcium channel blockers or thiazide diuretics. For hyperlipidemia, generally we should avoid statins and Zetia. We should strongly encourage lifestyle changes, and if there's a need for medications, a bile acid sequestrant like Welchol is preferred. For antiepileptics, you should generally avoid valproic acid because it can cause congenital malformations. Lamotrigine and levetiracetam are good alternatives. For analgesia, you should generally try to avoid NSAIDs because NSAIDs can cause a rare but serious kidney problem in the baby. Tylenol is considered to be very safe. Occasional doses of opioid during pregnancy is generally considered low risk, but poses risk in the first and third trimester. Opioid use during labor can cause neonatal respiratory depression, and long-term use during pregnancy may result in neonatal opioid withdrawal syndrome. Antibiotics. So antibiotics is also another broad subject. So I'm just going to be focusing on antibiotics for UTIs. You should avoid quinolones and also try to avoid Bactrim and nitrofurantoin in the first trimester. Although package insert does say that if there are no other options and the patient can't take anything else, then the benefits of treating the UTI with Bactrim and nitrofurantoin outweighs the risk of leaving the UTI untreated. Nitrofurantoin should also generally try to be avoided in the last month of pregnancy because it can cause hemolytic anemia in the baby. Alternatives, so safer medications include cephalosporin, fosfomycin, and then Bactrim and nitrofurantoin in the second and third trimester. Other medications to be alert for are methotrexate, serums like raloxifene and tamoxifen. You should definitely avoid the infamous thalidomide, avoid topical tretinoin, avoid warfarin. However, warfarin may be used in pregnant patients with mechanical heart valves after the first trimester.
Can you even get thalidomide anymore? I feel like, why are we still talking about it? I've never seen it ever used or prescribed.
I'm sorry, I caught the tail end of that question.
Thalidomide? Is it even used anymore?
Yes.
We're still talking about it.
Ever.
I've never seen it. Okay.
Yeah. Yeah, I've never seen it either. So other medications to avoid are aromatase inhibitors like letrozole, cannabis. DOACs should be avoided. The preferred anticoagulant for pregnant patients is still low molecular weight heparin. Live vaccines should be avoided. Gonadotropin releasing hormones like estrogen and testosterone, isotretinoin, and then high or frequent use of melatonin. So the fourth strategy is knowing what resources we have available to us. As always, UpToDate is available to us. UpToDate is great because it uses the Lexicomp drug information resource. So Lexicomp will provide all the risk assessment and clinical considerations that you would see in a drug package insert. Mother to Baby Fact Sheets is a great website that has patient-friendly pamphlets that you can give to mothers about the uses of medications and its effect in pregnancy. LactMed is a database that I use all the time for our nursing mothers. Infant Risk Center is also a great website with a lot of different topics around medications and pregnancy. Okay, so that concludes my presentation. Do you all have any questions?